So in the interest of time, I'll just have you seated as fast as possible, please, and I'll then introduce Dr. Mark Tarnopolsky. Okay, so Dr. Tarnopolsky works in the Department of Pediatrics at McMaster University. Mark's main research is looking to enhance muscle function in people with acquired and genetic neuromuscular diseases and mitochondrial dysfunction, with particular interest in the potential for exercise, pharmacological, and nutraceutical intentions to enhance muscle function and improve muscle mass. So please welcome Dr. Tarnopolsky.
Great. Thanks very much. So in the interest of time, I'll get going because this is a very difficult topic to go through in an hour, much less a half an hour. So I'll be talking about nutrition and exercise in muscular dystrophy. This will be a very brief overview. So from a disclosure perspective, these are my disclosures. I won't go through all of them. So in our clinic, we've been very interested in trying to enhance function in people that have mitochondrial disorders and those who have atrophy due to muscular dystrophy and other disorders. So we've been interested in trying to understand in healthy individuals what are the molecular signals which promote muscle hypertrophy and strength, and to evaluate how nutrition and other strategies, including drugs and different types of exercise, can promote strength enhancement. We're also very interested in what promotes mitochondrial biogenesis and enhances endurance exercise adaptations. And the reason we've been studying young individuals is that we can do multiple muscle biopsies, AV catheters, and we can get a lot of information from the molecular perspective to apply to our patients who are a little less willing to give us 6 muscle biopsies. So we're very interested in mitochondrial dysfunction, not just in patients with primary mitochondrial disease, but everyone in this room has a mitochondrial disorder called aging. So all of you will be slowly accumulating point mutations, deletions in your mitochondria. And if I were to biopsy anyone in the room over 65, we would start to see ragged red fibers, COX-negative fibers, and other signs of mitochondrial dysfunction. And that's exacerbated in disorders where there's immobility. We've actually found that if we put an immobilization brace on young university students, in 2 weeks we lose 30% of their mitochondrial mass. And that's regulated at the transcriptome level right down to the enzymatic level. So we've been trying to figure out, based on what we've learned in healthy people, how we can apply this to our patients with disorders. And of course, muscular atrophy is the antithesis of hypertrophy, and strategies to improve hypertrophy, hopefully, and as you'll see, can be applied to those with atrophy with some success. So not just the common disorders that we see in the clinic, like muscular dystrophy and mitochondrial disease, but a whole host of disorders, including obesity, diabetes, and other things have secondary mitochondrial dysfunction. So the first thing I'm going to talk about is nutrition. So the first question from a nutritional perspective is, are people getting enough? So in this study, which was published in Muscle and Nerve in 2005, we looked at 51 patients who had myotonic muscular dystrophy type 1, limb-girdle dystrophy, and FSH dystrophy. And we had 14 boys who had Duchenne muscular dystrophy who were less than 16 years of age. And we did a prospective dietary analysis. So on 2 weekdays and a weekend day, we had them write down everything that they were eating with nutritionists going over how to record this. And then we repeated it again 5 months later and took the average. We took the mean value of those 2 analyses and we compared it to the Canadian dietary reference intake. And this is what we found. In white are the adult patients. So again, that was myotonic, limb-girdle, and FSH patients. And in green were our boys with Duchenne dystrophy. So what this represents is the proportion of patients who are not meeting the dietary reference intake for Canadians. So you can see that things like energy, and that's pretty expected, because if people aren't moving very much, they don't need as much energy. Otherwise, they're going to be in a net positive energy balance, and they're going to get overweight. But you can see that if you're not taking in as much energy, a whole host of vitamins and minerals become somewhat deficient as we go through. Important things like vitamin D, which we know now, if it's very low, can actually negatively influence muscle. Things like vitamin B12, which if it's very low can cause neuropathy, which is the last thing somebody needs if they've got muscular dystrophy or mitochondrial disease. The other thing that we recorded was body mass index. What we have here are DM1 is myotonic muscular dystrophy type 1, 29 patients, limb-girdle and FSH, those are 21 patients, and patients with MELAS syndrome, which is a mitochondrial disease. And most people think when you look at patients that they're all going to be underweight. But in fact, anywhere from 10 to 18% of our patients met the criteria for being overweight. Many of them were obese. In fact, in our boys with Duchenne dystrophy, by the time they're 16 years of age, especially if they're on steroids, many boys are 50% or higher body fat. So 50% of their body mass is adipose tissue. So that's a problem, one, because they have to carry all of that weight, but two, as boys are living now to men, and we have boys, men with Duchenne who are in their 40s, we have to think about the cardiovascular risk factors of obesity, which is important. So the other way of looking at it, and you'll say, oh my goodness, Tarnopolsky, why haven't you published this stuff? It's because our new system with our computers, we can't go back and retrospectively look at our patients in a very effective way. So we went back to the old EMR system where I could extract this data. So that's why this 6-year data is so old. But what we did is I finally got access to this data, and we looked at almost 2,000 of our patients, half men, half women, where we had blood tests that looked at least one of the vitamins that are listed below: red blood cell folate, B12, vitamin A, vitamin D, and vitamin E. And we wanted to see what proportion were insufficient. And what we have here in blue are patients with muscular dystrophy. In pink are patients with peripheral neuropathy, because people certainly with peripheral neuropathy are always checking vitamin B12 because it's the second or third most common cause of peripheral neuropathy, but not many people think to check it in muscular dystrophy. And what we see here is if you look at red blood cell folate, almost 10% of our patients with muscular dystrophy were below the lower limit. B12, almost 18% of MD patients were deficient in vitamin B12. And that's critical because if you already have weakness and then you throw on top of that a myelopathy or a peripheral neuropathy, that's probably not well tolerated. And vitamin D is an important one. I'm sure most people who work in clinics realize now how many patients are vitamin D insufficient. What we have here are the proportion who are not just insufficient, but are deficient. So this is in the rickets range. And in the old days, when lots of kids were getting rickets, we remembered that these kids also got a myopathy. And I've actually been referred many patients over the last several years who had weakness, hyperCKemia, and the only thing we found was non-detectable vitamin D. And when we replace it, their CK normalizes and their strength comes up. So identifying that 12 to 14% of your patients have rickets range vitamin D, not just bad for the bones, it's not good for the muscles. But if we look at the current guidelines for insufficiency, 85% of our patients are insufficient to meet current Canadian guidelines based on blood values for vitamin D. Unfortunately, our, I won't use the word decerebrate, but to some extent their decisions are, government will not allow us to measure vitamin D in Ontario. It charges them $85 a patient to measure vitamin D. But they tell us that 400 units is the maximum amount that you give to pregnant women, but most people don't need vitamin D supplements. Anyone, I think, who has ever actually worked in a clinic or measured realizes that that is closely, if not decerebrate, recommendation. Most patients need 2,000 units to come close to meeting current Canadian guidelines. So what are some of my recommendations? Well, I think it's pretty clear that most people who have weakness aren't moving very much, and as a consequence, their energy intake is low. If your energy intake is low, especially if you're using calorically dense foods that aren't nutritionally dense, you're going to be deficient in vitamins and minerals. So as I say, I think that's because of the low resting metabolic rate. Another issue that can come up is food preparation can be difficult for some people, just lifting up a plate, getting into a fridge, and certainly in Ontario, and I'm sure it's the same across the country, support services for patients are pretty limited. And so people sometimes are skipping meals. At least 30% of my patients, when they see me in the afternoon of clinic, still haven't had a bite to eat. So that's a huge time where they're fasting and not eating very much. For many patients, there's a fear of swallowing. And certainly patients with oculopharyngeal muscular dystrophy, it's a canonical feature of the disease. Myotonic dystrophy type 1, as we've just heard, that is a very common feature. And we also see that in oculopharyngeal muscular dystrophy and in inclusion body myopathy. Those three disorders, anywhere from 50 to 100% of patients will have dysphagia, posterior oropharynx. And why it's important to pick that up is people have a fear of eating. They don't eat very much, but most importantly, it is treatable. Most of these individuals will have esophageal dilatation, which helps, Botox into the right spots, and if need be, sometimes a PEG tube, although that's a last resort. So some of the suggestions that we would recommend is we always ask about dysphagia. It's usually solids first if it's due to muscle weakness, and then eventually liquids. If they're having dysphagia, we do a swallowing study. Not a barium swallow, but a swallowing study. If that's abnormal, we refer them to a gastroenterologist who knows how to deal with these things. We would recommend taking a balanced multivitamin because most people are not getting enough energy intake and therefore they're not meeting the current Canadian DRIs. We also check for deficiencies. So every patient who comes to see me at first gets a vitamin D checked. Fortunately, our hospital pays for it. We get a vitamin B12 checked, and we always check vibration to look for neuropathy in all of our patients, and we treat them as appropriate. The other important thing I think to remember is a deterioration in function in a patient isn't always their disease. We've had patients with Friedreich ataxia who had non-detectable vitamin E who were getting worse. Probably the last thing a patient with FA needs is low vitamin E. We see patients who have severe vitamin D deficiency with muscular dystrophy. Again, that alone can cause weakness, so something you don't want to miss. It's the low-hanging fruit. And certainly in children, if they're falling off the growth curve and they're having difficulty maintaining their muscle mass and getting in some of their vitamins, minerals, and other medications, we're pretty quick to put a PEG tube in those kids if needed. So I'm going to talk briefly about a few specific nutrients and supplements. The first one is creatine. So creatine, if anybody had any of that meat this morning, you would have had some creatine. Creatine is found in meat and fish, and we get about 1 gram per day if we're a meat eater or fish eater. The other source of creatine is from our liver. So the kidneys make guanidino acetate. Unfortunately, my pointer doesn't seem to work here. No, if I click on it, it doesn't work. So our kidneys make guanidino acetate, which then goes to the liver, and it's converted through GAMT to creatine. We get about 1 to 2 grams per day. Most of the creatine is taken up into skeletal muscle and brain, but muscle is the main repository for creatine, where it's used as an energy source. And also with higher amounts of creatine, we slow down muscle protein breakdown. And that's important because many patients with muscular dystrophy have elevated rates of protein breakdown. So it may be a benefit, and I'll show you that it is in a minute. Creatine is non-enzymatically cyclized to creatinine and excreted in the kidneys. And so that's why creatinine is a marker of muscle mass and why most of our patients with MD have low creatinine levels. And that's excreted in the kidneys, as I mentioned. So when you take creatine, creatinine will go up a little bit, not because your kidneys don't work, because you've increased the rate of appearance of creatinine to the nephron. And so those who don't understand biology think that it's kidney failure, and they say, oh my God, creatine is going to cause kidney disease. No, it's not. It's just actually increasing your muscle mass. So the RA increases, not the RD. So why did we think to use creatine? Back in the late 80s, there were a number of studies that showed that if you give people oral creatine, you can actually load muscle, and you can get a 10 to 25% increase in phosphocreatine, which is the active metabolic store, but the total creatine is what activates a number of genes, which I don't have time to get into. What's interesting is that similar results were found by giving people just 3 grams of creatine per day. So in the traditional sense, they called it loading, where people took 20 grams a day. However, it's clearly been shown that after 1 month, if you only take 3 grams per day, which is only about 2.5 to 3 times your normal dietary intake, you get the same level of creatine loading. What's interesting is 10% of the Danish and Norwegian population gets this much creatine in their diet. So if you think it's toxic, then Norwegians and Danes should be having lots of problems. And most of the studies have shown an increase in high-intensity power output, and they've also shown that creatine phosphocreatine goes up, cotemporal with an increase in muscle mass accretion, especially if you're doing exercise. And we've done many studies in older adults, as you can see there on your left, showing that if you weight train with creatine, you gain more muscle mass and strength. So why did we think it made sense to look in muscular dystrophy? Well, we had a bunch of biopsies kicking around in the freezer, so we decided to measure creatine phosphocreatine, and we found very low levels in mitochondrial DNA disorders, especially MELAS syndrome, muscular dystrophy, predominantly Becker and Duchenne, but we also saw that in congenital myopathies, and of course inflammatory muscle disease, where that had been shown previously by MR spectroscopy. So what might the benefits be? Well, first of all, if you're deficient, as we identified there, replacing a deficiency makes a lot of sense, more so even than supercompensating a sufficient state. But there have been studies that have shown increases in fat-free mass, as I told you, in older sarcopenic adults, increases in strength and power in older sarcopenic adults. It's been shown to have an antioxidant effect. Numerous animal models of ALS, Huntington's disease, and brain trauma have shown that creatine protects against oxidative stress and neuronal loss. It's been shown to improve mitochondrial function, especially in some of the animal models of neurologic disease. And one study in particular in the MDX mouse, which of course is relevant to Duchenne dystrophy, it was shown to attenuate some of the increases in intracellular calcium, which are thought to reflect an activation of the proteasome and calpains, which contributes to the damage. So people have done studies. These guys scooped us by about a year. This is a group out of Belgium, and they did a study with 15 men with Becker muscular dystrophy predominantly, and I think they had 1 or 2 limb girdles. It was a randomized double-blind study where they were on placebo or creatine for 12 weeks and crossed over. Again, you see 3 grams per day, which is a fairly low dose, and they looked at muscle strength and endurance, joint stiffness, muscle creatine content, and they also looked at bone breakdown using N-telopeptides. What they found in these boys and men was an increase in strength and endurance. There was a maintenance of the total joint score. So what they thought was that the contractures did not progress as rapidly. But what was interesting is the bone mineral density went up. And that was associated with a reduction in bone breakdown as reflected in the N-telopeptides. And that was kind of cool because we were just starting our study, so we actually added that because I kind of didn't believe it, but they were right. And then they also showed an increase in phosphocreatine, which is important to show that, like healthy human beings, muscle that is dystrophic can load with creatine. So we got a US MDA grant. It was published in Neurology in 2004. Where we had 30 boys who had Duchenne dystrophy. It was a randomized double-blind crossover study, so they were on it for 4 months, 2 months washout, 4 months on placebo, or vice versa. We gave them 5 grams per day, which is about 0.1 gram per kilogram per day. Importantly, half of the boys were on corticosteroids and half were not. Because we wanted to see if it was additive or to the corticosteroids. And we had a variety of outcomes. Bottom line is we looked at strength, we did DEXA scans to look at muscle mass, and we also threw in there the N-telopeptides to take a look at bone breakdown. So what we found is when the boys were on creatine versus placebo, the mega score, which is your sum of your MRC scores, dropped less when they were on creatine. There was an increase in hand grip strength only in the dominant hand, which is an important point to take home, and that is if you're doing activity, creatine tends to work better and it tends to enhance the benefits. There was an increase in fat-free mass as determined by DEXA scanning, and interestingly, we found a 50% drop in N-telopeptides. And we've gone on to do all sorts of stuff in vitro, showing the effect at the molecular level in osteoblasts in vitro, so it does seem to have a beneficial effect on bone. What's important is that this worked just as well for the boys on prednisone and deflazacort as it did for those on placebo. So it was additive to the benefits they were already getting. So I was involved in a meta-analysis of every study that had been published, and there's about 6 other ones. I don't have time to get into them. As I mentioned, we found about an 8% increase in strength overall in the boys with Duchenne, increases in phosphocreatine in boys with Duchenne. Meta-analysis of every study included 192 people with muscular dystrophy, and the average increase in the Cochrane review was 8.5% increase in strength and just over 0.5 kilo of fat-free mass. So some of you are underwhelmed by an 8.5% increase. Does anyone know the average increase over time with prednisone in boys with Duchenne dystrophy? Which Birch Griggs, who was involved in the original studies with Jerry Mandel, told me when somebody got up and said, oh, Tarnopolsky, that's useless. 6%. So you give someone corticosteroids, which are the most toxic drug known to mankind, for a 6% increase, and people thought 8.5 was useless. But you have to put it into context of a long period of time. It keeps people above a threshold of disability. And that was the net improvement there in the Cochrane review. So the other interesting thing is we know that prednisone is a very toxic medication, especially to bone, and there's lots of side effects with bone. Many of our boys end up getting severe osteopenia and osteoporosis with fractures. So we wanted to see, based on that N-telopeptide data, is there actually a beneficial effect on bone? So we took 4 groups of Sprague-Dawley rats, and the reason we use them is that we are giving our medications to kids who are growing, and the Sprague-Dawley rats grow throughout the entire phase. So we gave them prednisone control, we gave them creatine, and we gave them prednisone with creatine. And what we found, I I'm not supposed to walk over there, but my darn pointer won't work. But if you look in the top, that's bone mineral content, and the bone mineral content dropped a bit with the prednisone. It went up a bit with the creatine, but it was the loss was attenuated, or in fact totally prevented when you gave prednisone with creatine, which you can see on the top there. So it prevented the bone loss. We also looked at muscle fibers on the bottom there. It's a little bit complicated, but what you can see is when they had creatine or creatine plus prednisone, we had an increase in phosphocreatine, and it's harder to see there, but the area of the type 2 fibers actually went up. And that's important because the number one side effect of steroids at the muscle level is a shrinkage of type 2 fibers. Here we actually saw that they actually went up and increased. So part of the value, I think, is when kids are on prednisone, which almost all of the kids are, or deflazacort, the creatine not only has an additive effect, but it can attenuate some of the deleterious effects of the prednisone. So I don't have too much time to get into this one, but this is another study where we did a pilot grant, but the US MDA didn't think it was appropriate to fund the study. But I'll show you. It takes me a second to set it up. So what we thought is if creatine is helpful, there's a whole bunch of final common pathways in muscular dystrophy, including oxidative stress, mitochondrial dysfunction. So we thought a cocktail approach would be better. So listed on your extreme right is beta-hydroxymethylbutyric acid, that's HMB, creatine, alpha-lipoic acid, which is an antioxidant, conjugated linoleic acid, which has beneficial effects on attenuating fat accumulation, prednisone, a combination of all of our nutrient supplements, and the combination plus prednisone. And what those numbers represent is the ranking in the mouse group, and these all have MDX, which is a model of Duchenne dystrophy, for the different groups. So if you look at creatine, which has now actually been shown in a Cochrane review to be beneficial, you can see it was okay, but not great. It was the 5th best for average peak grip strength, the 6th best for grip fatigue, the 2nd best in rotor-rod performance. It didn't have any effect on creatine kinase activity. The fat pad, it was the 4th best. Creatine went up, of course, and internalized myonuclei is a marker of turnover. It was the 5th best. But if you look at the bottom two, the combination of all of them performed better than any one of them in isolation and better than creatine, which has been shown in a Cochrane review to be beneficial. But most importantly, and this is what I really think that we need to be thinking about, combining multiple strategies together. If you take our multiple nutrient combination with prednisone, look across the bottom there, the 1st best in grip strength, the 1st best in fatigue, 3rd best in rotor-rod, but you can see those numbers are all low. So generally that group performed far superior to all the other groups. So I'll finish with exercise. Briefly, I have 7 minutes and 37 seconds. All right, so endurance exercise, what might be the value? Improves cardiovascular health, and as I say, our patients are living much longer. I've got 40-year-olds who are accountants with Duchenne dystrophy, so we have to be thinking now about cardiovascular health and fitness, and we know that endurance exercise might be beneficial there. We know that VO2 max, or your aerobic capacity, is a major determinant of your lifespan and your health span, so these things are very important. Also, to prevent obesity. If I gave any one of you a 20-kilogram pack and I said, okay, go walk up a flight of stairs with and without that, you'll feel the difference. And yet, as I mentioned, many of our boys are over 50% body fat. If they could take that fat jacket off and go upstairs, it would be a lot easier in their activities of daily living to get around. Resistance exercise has been shown multiple times to improve muscle strength. It can increase bone mineral density. And the advantage also of increasing fat-free mass is skeletal muscle is your biggest repository for glucose disposal, which can lower type 2 diabetes risk. So endurance and strength training, I'll talk briefly about both of them. So what are the concerns, however? Old school stuff said, well, of course, you take the MDX mice and look at the damage when you exercise them. Yeah, but it's decerebrate. They took the mice, ran them on a downhill treadmill. And none of our boys are even going to do moderate exercise, much less do eccentric exercise running full speed down a treadmill. And they had damage. Of course they do. But it's completely non-translatable to a human situation. People have said that FSH dystrophy patients, because their right arm tends to be more rapidly progressive than the left, proves that exercise is bad for people. Most of these studies were very small N, they weren't placebo-controlled, and in some cases, when they had people doing exercise, after 4 months, they said, oh, they're still getting worse. But what they didn't have is a control comparator to show that it attenuated the rate of decline. And then there's, of course, concern that you're going to damage the muscle membrane and it won't repair. So there have been studies with Dystrophinopathy. If you shoot lasers at it, there's an impairment of the repair, and we know when we do eccentric exercise, there's damage to the muscle membrane, but it does repair. Okay, so IBM, won't go through this. Most of you are familiar with IBM, most common inflammatory myopathy in those over the age of 50. It causes deep finger flexion weakness, quadriceps weakness and atrophy, swallowing dysfunction, and there is no effective therapy in spite of a bazillion trials. So of course exercise won't work, but no, it does. So the only thing that we've ever found improves strength, the only thing that's ever been shown in a clinical trial to improve strength in IBM is exercise. So what we have here is a study out of the NIH where they took IBM patients, mostly males, and they did 12 weeks of resistance exercise training 3 times per week. And you can see the delta there on your far right. The improvements there, 39%, 120% increase. And think about many of the drugs that are approved. 4.6% increase in strength, and drugs worth, hundreds of thousands of dollars are getting approved. I mean, these are massive improvements in strength in these individuals. So Pompe disease is a disorder of acid alpha-glucosidase. Impairment in that gene leads to a dysfunction of the protein. It leads to an accumulation of glycogen within the lysosomes, which eventually burst open, causes weakness, and they get a myopathic disorder, both the children and the adults. There is a therapy called Myozyme where you infuse the recombinant enzyme into individuals. But what about exercise? Is exercise helpful in these folks? So this is the only properly controlled study that I've found. It's a Greek group, and they had 5 patients with Pompe disease who were on enzyme replacement therapy. They did 5 months of combined endurance and resistance exercise training, and they found depending on the muscle, a 15 to 50% increase in strength. And the most important thing there, you can see the 6-minute walk test improved quite substantially. I know there's some Genzyme folks here, but that improvement is much more than what you get with Myozyme in the RCT. But the important thing, what we see, is when we mix 2 together, that's where we see the benefits. I saw a guy on Tuesday who's started an exercise program and ERT. We had him on ERT with no exercise. There was about a 7 or 8% improvement. He started exercise. There was about another 14% improvement. So things work well together. Okay, we've got 3 more slides, and I think I'm going to make it in time here. So as I mentioned, the early MD studies were small in numbers, usually no control group. And if a resistance exercise was attenuating the rate of decline, you don't see it unless you have a control group. And there was no strong evidence based on these early studies for an improvement in strength. However, we've taken a look at this. This is myotonic muscular dystrophy type 1 patients. So these were DM1 patients matched for CTG repeat numbers. So they had on average about 280 CTG repeats. They were matched for age and sex and socioeconomic status. We had 32 control and 32 who had exercisers. What I mean by that is that for at least a year, they had maintained 2 days per week or more doing some form of formal exercise, either home-based or at a gym. We also had 7 starters, people who had started exercise, and we were able to measure them for more than a year. And I'll just give you the starter data there on our Biodex, which is very accurate, 24% increase in knee extension. But if we look at the folks who exercised versus those who didn't, knee extension was greater, arm flexion was greater, and max grip strength was greater. And that's important because hand grip weakness, as was pointed out, is a frequent problem for them in their daily activities and can lead to loss of your job, especially if it's manual labor. Whoops. So I got 2 more slides. So resistance training for MD, some of the more recent data, and this is out of John Vissing's group, very well controlled. He's one of the top guys in the world. So they had 8 individuals who did low intensity training, who had limb girdle and Becker muscular dystrophy for 6 months. And this is pretty standard training, 70 to 80% of 1 repetition maximum. They had an improvement in arm strength of 60%, quads by 35%. I've got 2 minutes left here, yeah. This is, see, I'm not lying right there, 2 minutes left, yeah. And then they also, there was another study by my friend and colleague Tanya Tavasalo in chronic progressive external ophthalmoplegia patients where they did 12 weeks of weight training 3 times per week. Again, standard weight training, getting up to 80% of the 1 repetition maximum where they're doing 8 to 12 repetitions. And they had a 15% increase in leg extension, 25% increase in double leg press. Endurance training, again, all of these are from John Vissing's group. First study was limb girdle 2I, which is FKRP, 9 patients, 50 sessions of 30 minutes of endurance exercise, ramping up to about 60% of VO2 peak, and they had a significant increase, not just in endurance capacity, but quality of life scores went up as well. In Becker muscular dystrophy patients, 11 boys and men, same sort of a program at 65% of VO2 peak, increase in VO2 max by 47%, 80% increase in the peak workload, and leg strength went along for the ride as well, and they had a 13 to 40% increase. With endurance training, strength actually went up. And then finally, NO5, which is a form of Mioshi myopathy, limb girdle 2L, again, similar sort of an exercise program at about 60% of VO2 peak. And again, here we had an increase in VO2 plus sit to stand time, which is a metric of your function, getting out of a chair, getting off a toilet. 30 seconds left. So exercise, endurance and resistance exercise, and there's another thing called high intensity endurance training, which I didn't have time to get into, but 2 studies in FSH have shown that that's beneficial. It seems to be very safe. Even in John's studies, when they did biopsies, there was no signs of damage, no increase in CK. Endurance, we generally recommend starting at 50% of VO2 peak, going up to 73 times per week. Resistance, start low, give people at least a day of recovery at about 40% of their 1 repetition maximum. Gradually, as tolerated, we try to get them up to around 70% of 1 repetition maximum. In general, if your strength is so weak that you're MRC grade 2, so you can't move through gravity, that muscle, probably better not to do any formal exercise. It's probably too far gone, and most of the studies show if it's less than 15% of normal, you won't get benefit. We always recommend a warm-up to get the joints moving. We usually do 3 sets of 12 to 15 reps, because if you do fewer reps with a higher weight, there may be risk for damage. So most studies, as long as you can lift that weight 12 to 15 times, you're not going to be doing damage. And we do a circuit set, so you don't just keep doing your biceps every time you go through. Do your arms, do your legs, do your core, and go back to it so the muscles have time to recover. We suggest a mixture of endurance and resistance, and I won't get into the rationale behind it, but usually immediately post-exercise, a bit of carbohydrate and protein can help to facilitate muscle protein synthesis. So those are all the folks. Thanks very much.